Our topic today is retinopathy of prematurity, past, present, and future. The first patient of retinopathy of prematurity was diagnosed in 1942 by Dr. Terry. He diagnosed a new form of childhood blindness occurred in premature babies, and the condition was called at this time retrolental fibroplasia. And it was not until 1951 when Dr. Camborne, Australia, linked this condition to extensive or uncontrolled oxygen therapy in premature babies. And based on this, the overuse of oxygen in premature babies was stopped. And ROP then continues to be the leading cause of childhood blindness. The disease at this time was classified into acute and chronic phases. The acute ROP was described to be the fibrovascular portion or component of the condition, while the retinal detachment was termed chronic retinopathy of prematurity. In 1970, first trial of transscleral cryotherapy for retinopathy of prematurity. This was done in Japan, and the 10-year results of this treatment was published in 1980. Showed promising result. However, there was no guidelines for this treatment modalities. Okay, also there was no clinical data regarding the efficacy of this condition and its safety. In 1994, cryo-ROP study was initiated. It's a large multi-center study conducted in the US. The primary goal of this study was to resolve the uncertainty about the value of cryotherapy management of retinopathy of prematurity. As a part of the study, a group of 11 ophthalmologists, a group of 23 ophthalmologists from 11 countries convened, and they put the international classification of retinopathy of prematurity. They classified this disease into 5 stages, and they also classified the location of the disease into 3 zones, and they defined the plus disease as well. Just in brief, stage 1 is a demarcation line which separates the vascular from avascular retina. When this line gains volume, it's stage 2 in the form of ridge. Then when the condition progresses more, the fibrovascular tissue grow. This is stage 3, and if the condition is left untreated, this will lead to partial retinal detachment, stage 4, and then total retinal detachment, stage 5. And stage 5 was the one described by Dr. Terry as a retrolental fibroplasia. The location of the disease, according to the international classification of ROP, zone 1, is a circle centered by the optic disc, and the half radius is double the distance between the optic disc and fovea. Zone 2, circle centered by the optic disc and tangential with the nasal ora serrata, and the temporal crescent, zone 3. The international classification also defined the blast disease as a dilatation and tortuosity of blood vessel in the posterior bole, and blast disease was used as a strong indicator of activity of retinopathy of prematurity. The aggressive posterior bole disease was also described according to the classification. The first term for this was the rush disease, which means that severe blast disease and new vessels in the posterior bole, and so aggressive posterior bole disease does not respect the normal staging. It can go to stage 3 directly without going through stage 1 or 2. This study, the indication for treatment was threshold disease, which is defined as stage 3 zone 2 or in zone 1, involving 5 continuous or 8 discontinuous clock hour with plus disease. Study this is an example of threshold disease, and in this study, one eye received cryotherapy while the other eye was left as a control without treatment. And the result of this study after 10 years showed that the cryotherapy has reduced the blindness from retinopathy of prematurity by almost 50%. The blindness in treated eyes was 22%, and 41% of the untreated or control group developed either blindness or unfavorable structural outcome in the form of retinal traction or retinal loss. In 1999 until 2004, trying to improve the outcome of retinopathy of prematurity, the early treatment was considered because theoretically, if we treat early, we might get a better outcome. And this study was defined in this study, which is the early treatment group, they decided to interfere or treat in the pre-threshold stage. They even classified the pre-threshold stage into two groups. Group 1, which is high risk, Group 2, which is low risk. Low risk means if we have an ROP in zone 1, any ROP in zone 1 was plus disease, okay, and zone 1, stage 3, without plus disease, zone 2, stage 2, with plus disease, and the milder cases was termed ROP type 2, which means that zone 1 or zone 2 without plus, zone 2 or zone 2, stage 3 without plus disease. Okay, the 5-year result of this early treatment found that the unfavorable structural outcome was reduced early treatment group, and the unfavorable outcome retinal attachment occurred only in 9% of the cases compared to 22% in cryo-ROP study, which means that the early treatment reduces the blindness from retinopathy of prematurity furthermore. Starting from mid-1990s, the laser using indirect laser, either argon or diode laser, have gradually replaced the cryotherapy, and it was found to be less traumatic to the eye and causes less cardiopulmonary distress during anesthesia. And one of the advantages of laser therapy is only the here I will explain the advantage of laser therapy compared to other treatment modality. It's done once. Very rarely we need to repeat the treatment. Success rate is almost more than 90%, and follow-up is definite. We need only to follow the patient for only 1 month after laser therapy. However, the main disadvantage of laser therapy is that it needs general anesthesia. After general anesthesia, usually it's very hard to extubate the child, and there is a need for neonatal ICU after laser therapy, which make a lot of logistic arrangement in order to, perform the laser in a hospital and then shift the patient to the NICU, or perform the laser only in a hospital with an ICU. The problem also with laser that it has a limitation in posterior ROP, as shown by the ROP study. The previous study showed that there is a high chances of almost 40% retinal detachment rate in cases of posterior ROP. One of the problem also of laser therapy is a visual field. And I will show here one of the cases. This child I treated 2007 was Dr. Shima, child with acute aggressive posterior border retinopathy of prematurity, and at this time the use of anti-VEGF was not common in ROP, and we decided to laser avascular retina in both eyes. This is the right eye, optic disc, fovea here, and patient ended by a reasonable vision. Posterior pole is still there, the area between the arcade. However, there is a significant visual field contraction. And this is also one of the limitations of laser therapy is contraction of the visual field. Starting from new millennium, the use of anti-VEGF has become popular in the management of retinopathies, including diabetic retinopathy, and ophthalmologists thought of using the anti-VEGF for management of retinopathy of prematurity. One of the main landmark studies for use of anti-VEGF is BEAT ROP study, which is bevacizumab eliminate the angiogenic risk or threat for retinopathy of prematurity in 2011, and more recently the Rainbow study, which studies the Lucentis in the management of retinopathy of prematurity. Both of these landmark studies compared the use of anti-VEGF against laser in type 1 ROP. Type 1 here means the pre-threshold ROP. And the result of both showed that zone 1 disease, anti-VEGF is superior to laser treatment. And in zone 2 disease, they are equal, almost equal, despite that the result of anti-VEGF slightly better. However, this is not significant. This is not statistically significant management of ROP, which means that in the future, people are shifting gradually from laser therapy to anti-VEGF in the management of retinopathy of prematurity. The advantage of anti-VEGF therapy here, number one, is ease of use. We discussed before that in order to give laser for a patient with retinopathy of prematurity, we need to give it under general anesthesia, endotracheal intubation. There is a need of an ICU. However, using anti-VEGF, the injection can be done at the bedside with only using topical anesthesia, and so there is no need for a general anesthesia. This can be done on your convenience with a very little preparation in terms of equipment, in terms of staff. The advantage number two is rapid response. Laser takes 2 to 3 weeks to control the retinopathy of prematurity. However, in anti-VEGF, response is almost seen on the second day. Better visual field. The problem with laser is laser will ablate and destroy the periphery of the retina permanently. However, this is not the problem in anti-VEGF. So this is better visual field. And here there is one study about this. See here, this patient on the upper left. Okay, this is a pre-threshold or type 1 ROP. Patient received laser treatment. Here, these arrows are the edge of laser therapy. These vessels, these straight vessels are the choroidal vessels, and the retina in the periphery has permanently destroyed compared to the image here, the image C, showing the extensive ROP almost in zone 1 with extensive new vessels. And after anti-VEGF injection, 13 months later, the vessel has grown and has reached to the periphery with no visual field contraction. And this is one of the advantages of anti-VEGF. Better visual field, visual acuity. In the BEAT ROP study, the average amount of myopia was found to be minus 0.9 in the anti-VEGF group, and it was minus 4 in the laser group, which indicates better visual acuity with the use of anti-VEGF compared to laser. However, the use of anti-VEGF is not without complication or without disadvantage. The first disadvantage is delayed vascularization. Okay, we all know that VGF is very essential for normal development of retinal blood vessels. Also very essential for normal neural development of the retina. When we inject anti-VGF in the vitreous to control ROP, this will also delay the migration of the vessel to the periphery. So if you will inject, you have to be prepared for a very long follow-up. You have to follow the patient up to, I would say, up to the 60 or 70 weeks of gestation, sometimes even further, until the retina is fully vascularized. Normal retina should be vascularized by 40 or 42 weeks of gestation, but after anti-VEGF injection, this process can take even longer time. Number two, recurrence. Recurrence means that recurrence of the blast disease, recurrence of the new vessels, which will need either laser therapy or re-injection. We usually don't repeat the anti-VEGF injection except after 6 to 8 weeks. Challenging follow-up. As I mentioned, the long follow-up means that the child becomes bigger and stronger, and sometimes examination becomes very difficult. Systemic absorption. Okay, VEGF is essential for development of kidneys, lung, and systemic. The VEGF was retrieved from the blood even 2 weeks after injection, and we don't know, maybe it will cause any systemic effects. There is also other risk, including endophthalmitis cataract. Okay, and so in the previous part of the lecture, we have gone through the evolution of ROP treatment, starting from no treatment, and then the application of cryotherapy, and then the guidelines for cryotherapy, and then how we shifted from cryotherapy to laser treatment, and then how now we are shifting from laser treatment to use of anti-VEGF. Okay, we will go through the ROP screening. ROP screening become mandatory in most of the developed and modern countries all over the world. These are the methods of screening: conventional screening, wide field digital camera screening, remote screening, and more recently, and will be developed in the future, is automated screening. These are the national guidelines for ROP screening in Saudi Arabia, which mean that all babies more than 1,500 grams or born less than 32 weeks of gestation, or selected infants between 1,500 to 2 kilograms with unstable clinical condition, or who have received prolonged ventilation. This should go through the screening process of retinopathy of prematurity. The screening is initiated by pediatrician in charge in the NICU. And the screening should be performed by ophthalmologists with sufficient experience in ROP diagnosis and management, and he should be familiar with disease changes and location of the disease. We'll start by traditional screening using indirect ophthalmoscope. This is how we started the screening. Then examine the every quadrant of the fundus, and then record the finding standard ROP documentation for. Okay, and then the problem with this form of screening is it's difficult to perform in a tiny small baby. Number two, we have to do scleral depression or scleral indentation in order to see the periphery of the fundus, which is sometimes difficult, especially again in this fragile baby. Number three, the follow-up is difficult, and you cannot compare two visits, especially if more than one examiner is doing the screening. Because of this, the wide field digital camera screening is more superior. Because in this wide field digital screening, the field of view is 130 degrees compared to only 40 by indirect ophthalmoscope. So there is better evaluation of the zone or location of the disease. Number two, there is a digital documentation, and even if more than one examiner is following the patient, he can go and review the previous images and to evaluate, to have an impression if the disease is progressing or not. This is the advantage of digital camera wide field screening compared to the old or traditional screening using indirect ophthalmoscope. The third or the next advancement in the screening is remote screening. The remote screening means that the wide field digital camera is distributed in the ICU units. Images are taken by either technician or a nurse, and then the images are sent to the reading center. Central data analysis or reading center will review the images and send an e-consultation to the MIC units, deciding which patient needs further follow-up and which patient needs treatment. This is the first ROP telemedicine all over the world. It was performed in Germany, in Bavaria in 2001. After that, many network have been in action in Europe and in the United States. The first attempt to make a network was a mini network between Haferbauten and our hospital using a mobile app. This was in 2017. However, the Saudi Arabia National ROP Telemedicine Network have started in 2019. One was this network is, as far as I know, the first ROP telemedicine network over the Middle East. The first organized network, and I believe more than 40 RedCam units were distributed in ICUs of Ministry of Health in all over the kingdom. Still not all area covered. And still also we have non-MOHs are not covered by this network. And this network images are captured by nurses, and then the images are sent to the reading center in Riyadh. Reading center in Riyadh evaluate the images and send an e-consultation to these centers. Okay, and cases needs treatment are referred for treatment. Still, this project in its infancy, and still there is a large room for improvement. This is the future in ROP screening, is automated ROP screening, and this automated in this system, the automated ROP screening using the artificial intelligence to take the ROP screening into another level. The level is to be a fully automated using a technology called deep learning based technology. This technology based on feeding the computer with thousands of images with the detailed report and description of the images, and using the artificial intelligence technology, the computer will identify which eyes needs treatment, which eye needs follow-up, and also it will give every decision a score. A score beyond some limit, indicating that this diagnosis is definitive. Low score indicating that this report need to be reviewed by ophthalmologist. The idea of automated screening is to improve the efficacy and accuracy and objectivity of ROP diagnosis, also facilitating quantitative disease monitoring and risk prediction. Okay, I believe that in the future, most of the ROP screening will be automated. and the majority of ROP treatment will be using VEGF. And this will definitely improve the outcome of ROP. And still, a lot of effort need to be done in order to improve the care of premature babies in the ICU, and this will also reduce the frequency and the intensity of. Okay, thank you very much. I'm done by now, and we can start discussion if you like.
Eh bien, le perce-oreille, comment appelle-t-on un demi-abricot? Un oreillon. Les oreilles d'abricot, vous n'avez jamais entendu parler? Je suis un peu parfois consterné par votre savoir. Pour rien vous cacher, j'ai de vous fausser en tête de jardinier qui vous regarde et qui vous écoute. Fait revenir, je le disais, les oiseaux, quantité, même les poissons.
للاسف يا جماعه الصوت يعني الصوت مش واضح خالص. Sound is not clear.
Thank you very much, Dr. Khalid. Was a very informative lecture. If there is any questions from the attendee, feel free to ask.
Thank you, Dr. Khalid, for the lecture. I was wondering regarding now the telemedicine that the Saudi is planning to do as a national level. What was implemented so far, and what's the future plan? Thank you.
Okay, what was implemented is as I mentioned, Medcam or wide field digital camera was distributed. It was distributed to, I believe, 40 locations over the kingdom. Okay, maybe 50 or 60% of the MICUs. Still, there are centers need to be included. And as I mentioned, the area for improvement is to purchase or to provide more units to cover all MICU location over the kingdom. Okay, the reading now is performed in King Khalid Eye Specialist Hospital, and still treatment is still there is some difficulties in treatment. Okay, because of the logistic of patient transfer, and some patients are transferred from a very long distance areas, and so this is also another obstacle, and they have to work on this. Okay, and I believe if patients are caught early and treated with anti-VEGF, I believe this would make this problem.
Dr. Khalid, what I was wondering, were they planning that the screening, once it is done in Khalid, they will refer the case itself to hospitals that is near the patient location?
Yes.
And the treatment will be done there?
Yes.
Okay.
And so the plan, for example, cases cases will not move, for example, from Eastern province to be treated in Red. Cases in the Eastern province, Northern area will be treated in the Eastern province. And cases,
as far as your knowledge, was this implemented or yet to be implemented?
It's implemented.
Oh, okay. Thank you, doctor.
Okay, شكرا جزيلا. Thank you.